So good morning, everyone. I'm Larry Boris with the National Association of Worksite Health Centers. I want to welcome you to our program today. We're very pleased to have with us Captain Sarah Luckhart, a physician with the CDC, and I'll introduce her just in a moment later. This is an opportunity for us to share with you information about the COVID-19 update and the vaccine distribution plan as developed by the CDC and NAWHC and the vaccine unit for the federal government. We wanted to make information available for our membership and others who are interested in this issue as relates to your services at your worksite health centers. For those who are not familiar, the National Association of Worksite Health Centers is the nation's only nonprofit group helping employers and vendors, unions, partners, hospitals, and others who have on-site, near-site, virtual, shared, mobile health, pharmacy, and wellness centers. We have a variety of programs and information. If you're interested in learning more about our organization and its activities, please visit our website at www.nawhc.org and be sure to join our LinkedIn group so for you get updated information. This is just one of a number of programs we have focusing on the vaccine distribution plan. As Sarah will talk to you in a little bit, there is a national CDC virtual forum on February 22nd to 24th that'll be available. That you can sign up for at no cost. NAWHC is having two other programs. One where our partner Mercer will be talking about the employer vaccine decisions and some best practices that they have found throughout the country and that they're making recommendations to their client base regarding vaccine decisions. And then we're going to have two of our members, both an employer and their clinic vendor partner, talk about how they've already acquired the vaccine for their on-site centers, and they'll be talking about how you can do that as well. We are partnering with the World Conference Forum, June 24th to 25th, for their on-site employee clinics summit in Chicago, and then our own annual forum will be September, actually not 9 to 20th, it won't be that long, it'll be just the 9th and 10th, my typo, also in Chicago. That'll be our national meeting. Hope you can join us there. Today's speaker, as I said, is Captain Sarah Luckhart, physician. She's Associate Director for Science at the Division of Study, excuse me, Field Studies and Engineering at the National Institute of Occupational Safety and Health, or affectionately called NIOSH, which is part of CDC, and she's also a captain at the U.S. Public Health Service. She is a member of the Essential Workers team within the CDC COVID-19 Vaccine Task Force, and she has served as part of the Worker Safety and Health team at CDC for some time. And so with that, if you have any questions about our organization or COVID-19, feel free to contact me at this number or email. At this time, I'm going to turn the session over to Sarah for her presentation. Sarah, I'm going to change the sharing. I should be able to stop my sharing, I believe, and turn it over to you. So let me leave it to you. Sarah, it's all yours. Looks good.
Now I had to find my unmute button again. All right, so thank you. I'm very happy to be here again with this group. I spoke with some of you in September, and now I'm happy to have an opportunity to talk about what has happened since September, because a lot has happened since September, especially regarding the approval and availability of the COVID-19 vaccines. So I'll tell you a little bit about where we are now from the CDC perspective, but please note that this situation continues to evolve rapidly. So I suggest that you visit the CDC COVID-19 website frequently for updates.
Before you get started, I did want to remind everybody, if you have a question during the session, you can put it in the Q&A portion, the icon on the bottom of your screen, or we also have a SurveyMonkey link that was shown in the chat that you can submit your questions, and Sarah will get to those at the end of the session. Okay, thanks very much. Sarah, back to you.
All right, yeah. So I wanted to start by just briefly addressing some of the key facts about COVID-19 vaccination that we think everyone should know, and some of the common myths that are circulating. So first, getting vaccinated can help prevent you from getting sick with COVID-19. And second, people who have gotten sick with COVID-19 may still benefit from getting vaccinated. So due to the severe health risks associated with this disease and the fact that reinfection is possible, vaccines should be offered to you regardless of whether you already had COVID-19 infection. At this time, experts don't know how long someone is protected from getting sick again after recovering from COVID-19. So the third fact is that COVID-19 vaccines will not give you COVID-19. So none of the authorized and recommended COVID-19 vaccines or the COVID-19 vaccines currently in development in the US contain the live virus that causes COVID-19. So this means that it cannot actually make you sick with COVID-19, despite the fact that you may have some side effects from the vaccine. So COVID-19 vaccines finally will not cause you to test positive on COVID-19 viral tests, like the PCR test or the antigen test. It is possible that they will create some positive tests on antibody tests, but not on the viral tests for current infection. So next I wanted to present just a snapshot of where we are right now with COVID-19 administration in the US. So as of February 14th, over 52 million doses have been administered, including over 38 million persons initiating vaccine and 14 persons fully vaccinated. So in the map, the darker states and territories are those that have the highest percentage of their population vaccinated right now. And in the graph on the lower right, you can see that both of the vaccine products that are available so far have had more than 25 million doses administered. So CDC continues to work with states to understand roadblocks and figure out how to overcome challenges in distribution and administration to ensure that we are getting vaccines into arms as quickly and safely as possible. But you can watch these numbers increasing on the website every day. So now I wanted to quickly summarize the process of COVID-19 vaccine licensure and recommendations in the US. So as shown in the middle of the slide, the Food and Drug Administration, or FDA, is responsible for authorization and approval or licensure. So far, 2 COVID-19 vaccines have been approved by FDA under Emergency Use Authorization, or EUA. An EUA is a mechanism to facilitate the availability and use of medical countermeasures, including vaccines, during public health emergencies, such as the current COVID-19 pandemic. So under an EUA, FDA may allow the use of unapproved medical products or unapproved uses of approved medical products in an emergency to diagnose, treat, or prevent serious or life-threatening diseases or conditions, when certain statutory criteria have been met, including that there are no adequate, approved, and available alternatives. So taking into consideration input from the FDA, manufacturers decide whether and when to submit an EUA request to FDA. Once submitted, FDA will evaluate an EUA request and determine whether the relevant statutory criteria are met, taking into account the totality of the scientific evidence about the vaccine. So the Vaccines and Related Biological Products Advisory Committee, or VRB-PAC, is the group that reviews and evaluates the data concerning the safety, effectiveness, and appropriate use of vaccines and related biological products. So they're a committee of experts external to FDA that provides input upon request by FDA on certain regulatory actions, such as these vaccine EUAs. Then, as shown on the left, the Advisory Committee on Immunization Practices, or ACIP, advises the CDC, which makes recommendations for the use of EUA or licensed vaccines. And I'll describe that process in more detail now. So the ACIP includes 15 voting members responsible for making vaccine recommendations to the CDC. And the Secretary of the U.S. Department of Health and Human Services selects these members following the application and nomination process. 14 of the members have expertise in vaccinology, immunology, pediatrics, internal medicine, nursing, family medicine, virology, public health, infectious diseases, and/or preventive medicine. And 1 member is a consumer representative who provides perspectives on the social and community aspects of vaccination. So in addition to the 15 voting members, ACIP also includes 8 ex officio members who represent other federal agencies and 31 non-voting representatives of liaison organizations that bring related immunization expertise. Members and representatives serve on this committee voluntarily. So this slide summarizes recommendations for COVID-19 vaccine prioritization during limited vaccine supply from the ACIP. And these were published around December 20th of last year. So please note that while ACIP and CDC make national recommendations, we understand that there will be a level of local adaptation. And the phased vaccine recommendations are meant to be fluid and not restrictive for jurisdictions. It's not necessary to vaccinate all individuals in one phase before initiating the next phase. Phases may overlap. So for COVID-19 vaccine prioritization, the US adult population is broadly divided into overlapping categories based on occupation as an essential worker, as well as age and presence of underlying medical conditions. So in the first phase of allocation, or phase 1A, healthcare personnel and long-term care facility residents are recommended to receive the vaccine. These groups are followed in phase 1B by frontline essential workers and adults 75 years and older. And next are the remaining essential workers, adults 65 to 74 years, and 16 to 64-year-olds with high-risk medical conditions. And finally, in phase 2, 16 to 64-year-olds without high-risk medical conditions are included. So, as I said, while ACIP and CDC make national vaccine recommendations, there will be a level of local adaptation, and I'm sure we have all seen that already. Our guidelines are not walls or barriers between phases, but meant to support prioritizing people at high risk of exposure or high risk of severe disease. And we always anticipated that there would be overlap between vaccination phases. We also understand that the COVID-19 vaccination program is dynamic and will require ongoing reassessment as vaccine supply and demand and COVID-19 epidemiology change to inform the timing of expansion to subsequent phases. So AC and CDC have endorsed a couple of guiding principles of efficient distribution as well as jurisdictional flexibility for the COVID-19 vaccination program. So 2 vaccines have received EUAs from the FDA so far. The Pfizer-BioNTech vaccine, which consists of 2 doses given at least 21 days apart, and the Moderna vaccine, 2 doses given at least 28 days apart. Both of these vaccines were tested in tens of thousands of adults from diverse backgrounds, including older adults and communities of color. And clinical trial data show that both vaccines are safe and effective at preventing COVID-19. It is unknown at this time how long protection from the vaccines might last. As data on vaccine effectiveness become available, CDC will provide regular updates with that information. While there are no meaningful differences in these vaccines regarding efficacy or safety, there are some differences that have logistical implications for administration. So in addition to the differences in the age groups and dosing intervals that I already mentioned for these products, the big difference is that Moderna arrives in a thermal shipping container at between -25 degrees Celsius to -15 degrees Celsius, whereas Pfizer arrives in a thermal shipping container at between -80 degrees Celsius and -60 degrees Celsius, making the cold chain for these vaccines somewhat complex. Note that FDA has scheduled a meeting of its Vaccines and Related Biological Products Advisory Committee on February 26th to discuss the request for EUA for a COVID-19 vaccine from Janssen Biotech Incorporated. And their parent company is Johnson & Johnson. So you may have heard this referred to as either the Johnson & Johnson vaccine or the Janssen or Janssen vaccine, depending on how it's pronounced. So we realize that you may have concerns about the safety of these first COVID-19 vaccines because they use a new technology. They're mRNA vaccines. So it's important to know that these were developed based on years of research. While mRNA technology is new, it is not unknown. mRNA technology has been studied for decades in vaccine trials for influenza, Zika, and rabies. And also cancer research has used mRNA to trigger the immune system to target specific cancer cells. So we were able to fast track these vaccines because researchers used existing clinical trial networks, like those that study HIV treatments and vaccines, to quickly conduct COVID-19 vaccine trials. And another critical piece in the fast tracking has been the investment in manufacturing. Even before COVID-19 vaccines were proven effective, the US government and vaccine manufacturers invested millions of dollars to scale up vaccine production while clinical trials were still in progress, greatly reducing the amount of time between vaccine authorization and vaccine implementation. mRNA vaccines are also faster and cheaper to produce because they use ready-made materials. And FDA and CDC, again, are working quickly to prioritize review and approval of additional COVID-19 vaccines. So some of the complexities and additional considerations for implementation of COVID-19 vaccine that differ a bit from some of the other vaccines that have been administered in the past to adults, including flu vaccines, include the varying cold chain requirements that I already mentioned, the need for socially distanced vaccination practices while community transmission of this disease is high. Subprioritization may be required with initial limited supply. So even with these phases 1A, 1B, and 1C, we're seeing that there's not enough right now to necessarily vaccinate everyone within one of those broad phases at the same time. There's also the difficulty of the 1 versus 2 dose series and the fact that the different products are not interchangeable. And the vaccine efficacy and adverse event profile in different populations include facts like implementation of vaccination programs for healthcare personnel will need to consider reactogenicity post-vaccination and the implications for that. Safety monitoring of all populations is critical post-authorization, and communication and education are critical to the success of the vaccination program. So this is a high-level view of how we envision distribution adjusting as the volume of vaccine doses available increases. So as you know, we are currently in phase 1 with limited doses available, and the phase 1 priority populations are the focus. There's constrained supply, and rapid and efficient distribution with highly targeted administration is required to achieve coverage in priority populations. But we will eventually make it to phase 2, where there are a larger number of doses available and there's sufficient supply to meet demand, emphasis on rapid, efficient, and equitable distribution, and increasing vaccine confidence will still be important. As shown on the left, at first, the COVID-19 vaccines were only administered through healthcare facilities, including long-term care facilities and public health clinics. But as supplies increase, vaccines are being administered to broader populations through many different administration sites, including commercial and private sector partners such as pharmacies, doctors' offices, and clinics, and public health sites such as mobile clinics, federally qualified health centers, and other temporary or off-site clinics. So as the supply increases, the breadth of places where people could get vaccine will continue to increase. So this is a summary of how jurisdictions are approaching COVID-19 vaccination provider recruitment and enrollment. There is an emphasis on targeted outreach to providers that may specifically serve prioritized populations. For example, for employers of frontline essential workers, jurisdictions are being encouraged to reach out to existing occupational health providers that can be leveraged and enrolled to vaccinate these groups. And then there's some information about other groups too. We want to include providers from racial and ethnic minority populations, and especially those serving priority populations. And many times that overlaps with essential worker groups. So CDC has also outlined specific recommendations for certain subpopulations. So for example, while many long-term care facilities are participating in the pharmacy program, some smaller facilities and residential group homes in the community may need to be matched with another type of provider that can provide mobile vaccination services for these residents. And we're continuing to think about what are all the different ways that essential worker groups can be reached, including engaging occupational health clinics in these sectors where appropriate, and considering enlisting mobile clinics for essential workers who do not have access to occupational health services. As part of a national effort to speed the pace of COVID-19 vaccination campaigns, the President has directed the federal government to establish new federally supported community vaccination centers, or CVC. So this is an expanding partnership between CDC and FEMA on CVCs. So FEMA has released a playbook that establishes guidance for providing federal support to existing and new CVCs that are essential to accomplishing the mission, to include interagency coordination, resource support, facility setup, and other requirements that may necessitate federal support. And CDC is fully engaged in the National Response Coordination Center, working closely with FEMA on this. So this is something to continue to watch in the near future. Now I'm going to switch gears a bit and talk about what we mean by essential workers when it comes to COVID-19 phased allocation of vaccines. So here's the summary of ACIP priority groups that I showed before. And this time I have circled the essential workers that are included in phase 1A through phase 1C. So you'll see healthcare personnel in phase 1A, frontline essential workers in phase 1B, and other essential workers in phase 1C. We've received a lot of questions regarding essential workers and who is included in which phase. Shown here is a broad list of frontline essential workers prioritized under ACIP's phase 1B, as well as a list of other essential workers prioritized in phase 1C. ACIP used guidance on essential critical infrastructure workers from the Cybersecurity and Infrastructure Security Agency, CISA, which is part of the Department of Homeland Security, to define frontline essential workers as workers who are in sectors essential to the functioning of society and are at substantially higher risk of exposure to SARS-CoV-2 due to their work duties. These include groups like first responders, teachers and support staff, manufacturing workers, grocery store workers, food and agriculture workers, and others. And there are approximately 30 million frontline essential workers in the US. Other essential workers include those in transportation and logistics, food service, construction, and water wastewater, among others. And it's important to note that while ACIP makes recommendations on vaccine prioritization for jurisdictions when vaccine supply is limited, it's the jurisdictions or the states and territories that have the final say on how vaccine is distributed to their populations. CDC released a more detailed list to help state, local, tribal, and territorial officials and organizations prepare for the allocation of initially limited COVID-19 vaccine supply. So this interim list identifies essential workers in the same way as ACIP and CISA. They're essential to ensuring the continuity of critical functions in the US. And this list maps the CISA guidance to both standardized industry codes and titles from the NAWHC system to the corresponding COVID-19 vaccination phases per ACIP. And it also lists which sector described by CISA each of these groups falls under. So along with the MMWR outlining the ACIP recommendations that were made on December 20th and published on December 22nd, CDC also published supplemental information on considerations for sub-prioritization of frontline essential workers, recognizing that the supply may not be enough to reach all frontline essential workers at the same time. So these sub-prioritization considerations include thinking about workers where high rates of transmission and or outbreaks have occurred, workers at increased risk of severe illness based on age or underlying conditions, and workers who do not have a history of documented SARS-CoV-2 infection in the prior 90 days. And there are many potential challenges for the vaccination of frontline essential workers. A given jurisdiction may have a large number of frontline workers to vaccinate, and state and local health authorities may need to sub-prioritize, as mentioned. Workers may work in one state but live in another, which has proven a challenge, and a great deal of coordination and planning may be required to take advantage of the timing when staff are eligible to be vaccinated. Jurisdictions may want to consider the use of work sites to administer vaccine. Transient workforces, or workers whose jobs involve interstate transportation, may have difficulty getting the second dose. And as I mentioned, the two products that have been approved so far both require a second dose. In addition, given the variety of industry sectors included in the frontline essential worker category, there are many other special considerations and challenges that jurisdictions need to be aware of in vaccinating these populations. So some workers may have concerns about vaccine safety, so there's a need for culturally appropriate vaccination information in multiple languages, Rural areas have limited access to healthcare and health providers and may require targeted strategies for vaccine implementation, such as mobile clinics, and preferred methods of communication may be different for different groups. So one thing that CDC recommends is relying on community leaders to serve as trusted sources for information, and this includes leaders within the workplace. Critical infrastructure employers also have an obligation to manage the continuation of work in a way that best protects their health of the workers and of the general public. So making COVID-19 vaccination part of a workplace wellness program offers many benefits to employers and employees. To keep your workforce healthy, consider offering free on-site COVID-19 vaccination at your business locations. Employers considering implementing a workplace COVID-19 vaccination program should contact the health department in their jurisdiction for guidance. The planning process should include input from management, human resources, employees, and labor representatives as appropriate. Other important preliminary steps include obtaining senior management support, identifying a vaccine coordinator, and enlisting expertise from local public health authorities, occupational health providers, and pharmacies. Employers should offer the vaccination at no charge and during work hours, and they should also offer flexible paid leave policies for those workers that may experience post-vaccination symptoms. But if hosting a vaccination clinic at the workplace is not possible, we encourage employers and other groups to take other steps in encouraging vaccination of workers. You can encourage vaccination by providing information to your workers about where they can get the vaccine, being flexible in human resource policies, establishing policies that allow employees to take paid leave to seek vaccination in the community, and supporting transportation to off-site vaccination clinics. CDC also has some examples of promotional posters and flyers that can be used offering COVID-19 vaccination in the community, and these could be displayed in the workplace. You can also post articles in company newsletters about the importance of COVID-19 vaccination and where to get the vaccine in the community. So as part of the CDC response to COVID-19, the Vaccine Task Force created an essential workers team. And as Larry mentioned, that's the team that I'm on right now. And our mission is to focus on vaccine implementation for essential workers through linkages with workers, industry, labor, and other stakeholders. And our strategic efforts include disseminating information to enhance vaccine confidence in essential workers and supporting jurisdictions to implement vaccination strategies for essential workers. Our team consists of subject matter experts in all of the different sectors where essential workers work, and also surveillance, communication, immunization, and evaluation expertise. For the education part, to educate both essential workers and their employers around COVID-19 vaccines, CDC has created an essential workers communications toolkit. And this toolkit includes multiple adaptable resources to address common questions and concerns and raise awareness about the benefits of COVID-19 vaccination, including key messages and fact sheets, PowerPoint slide decks, frequently asked questions, posters and flyers, newsletter content, letter to members, and social media content. So please go to the link at the bottom of the slide to access the toolkit. And we encourage you to share this widely with your networks. And also let our team know if you have any feedback on the toolkit about how it could be made better. So unfortunately, we know that many people will be hesitant to get a COVID-19 vaccine, and this number has been increasing over time. According to this Harris poll conducted in October, before a vaccine was authorized or available, only about half of people said they would get a hypothetical COVID-19 vaccine. And we know that there are several factors that can impact vaccine acceptance, including concern about side effects, vaccine efficacy, risk perception, and associated costs. So worries and concerns about COVID-19 vaccine can impact people's willingness to get vaccinated, which is why we need to address them fully so people can be confident in the decision to get vaccinated. And this slide shows CDC's Vaccinate with Confidence strategy, which aims to build confidence in the vaccine through reinforcing trust, empowering healthcare providers, and engaging communities and individuals. It's not a communication campaign, but rather a framework for thinking about interventions to increase vaccine confidence. You may be getting questions from patients and employees about these vaccines. Although we do not have all the information about the vaccines yet, you can start planning now for how to communicate with patients about the vaccines when they become available. And here are some things to start thinking about. If you choose to get vaccinated yourself, you can serve as an example. You can engage in effective conversations, starting from a place of empathy and understanding, and addressing misinformation by sharing key facts, and being prepared for questions, sharing CDC resources and toolkits. Now I'm going to briefly discuss just a few of the clinical considerations for COVID-19 vaccine clinics that might be important as you plan a potential workplace clinic. So allergies are the big concern for triage of persons presenting for the mRNA vaccine. And persons with allergies fall into three categories. So those that may proceed with vaccination are included in the green box, and this includes those with a history of allergies that are unrelated to a component of an mRNA COVID-19 vaccine, other vaccines, or injectable therapies, so such as a history of food or pet allergies. And people with these allergies who have a history of anaphylaxis should be observed for 30 minutes, but they may proceed with vaccination. And all others who have allergies but haven't had a history of anaphylaxis only need to be observed for 15 minutes. So in yellow, the group who is at precaution to vaccinate include persons with a history of any immediate allergic reaction to vaccines or injectable therapies other than those that are related to a component of the vaccines themselves and polysorbate, and they can proceed with vaccination after a risk assessment and consideration of deferral of vaccination and or referral to an allergist immunologist, and should be observed for 30 minutes. So in the red box, the only contraindication to vaccination is those with a history of the following contraindications to receiving either of the mRNA COVID-19 vaccines. And that's a severe allergic reaction after a previous dose of one of these vaccines, or an immediate allergic reaction of any severity to a previous dose of the vaccine or any of its components, including polyethylene glycol. So most persons with allergies should fit into the green or the yellow category. And just another high-level overview reminder of the observation period. Persons with a precaution to vaccination or a history of anaphylaxis due to any cause should be observed for 30 minutes, and all other persons should be observed for at least 15 minutes after vaccination. CDC has also released interim considerations for preparing for the potential management of anaphylaxis at COVID-19 vaccination sites. Now, a bit about post-vaccination symptoms. Before vaccination, providers should counsel mRNA COVID-19 vaccine recipients about expected local and systemic post-vaccination symptoms. Depending on the vaccine product, age group, and vaccine dose, approximately 80 to 89% of vaccinated persons develop at least one local symptom, such as pain, swelling, or erythema at the injection site, localized axillary lymphadenopathy on the same site as the vaccinated arm. And 55 to 83% report at least one systemic symptom, such as fever, fatigue, headache, chills, myalgia, or arthralgia following vaccination. Most systemic post-vaccination symptoms are mild to moderate in severity, occur within the first 3 days of the vaccination, and resolve within 1 to 3 days of onset. These symptoms are more frequent and severe following the second dose and among younger persons compared to older persons. But both vaccines are highly efficacious, with vaccine efficacy estimated at 95% for the Pfizer-BioNTech and 94% for the Moderna vaccine. But efficacy after a single dose has not been systematically evaluated. Thus, patients should be counseled on the importance of completing the 2-dose series in order to optimize protection. Limited information regarding how much the vaccine may reduce transmission in the general population and how long protection will last is available right now. So for now, we do know that protection from vaccine is not immediate, These vaccines are 2-dose series, and it will take 1 to 2 weeks following the second dose to be considered fully vaccinated. And no vaccine is 100% effective. So at this time, vaccinated persons should continue to follow all the current guidance to protect themselves and others, including wearing a mask, staying at least 6 feet away from others, avoiding crowds, washing hands often, following CDC travel guidance, and following any applicable workplace or school guidance. So, in conclusion, this is an exciting and historic time, but the work is far from over. There will be unanticipated challenges, but CDC will continue to work closely with you, our partners, to find solutions and overcome obstacles. Vaccines are an important tool to control the pandemic, but we need to continue to message the importance of masks, social distancing, and hand washing. And community engagement is critical to vaccination implementation success. So engage in conversations in your community, choose to get vaccinated when it's your turn, and share CDC resources and toolkits. So right now, you can know where to go for the latest accurate information on the COVID-19 vaccines, understand your facility's plan for vaccination, connect with your local public health department and ask how you can help, and help carry the message because you are a trusted source who understands your community best, and you can engage with community partners to address vaccine hesitancy. And I'll just end with a quick advertisement for the event next week that Larry mentioned earlier. The National Forum on COVID-19 Vaccine will be taking place on Monday through Wednesday. So I encourage everyone to check out the website and see if that's something that you might be interested in participating in.
Great. Thank you very much, Sarah. That was very comprehensive, a lot of information. What I'm going to do now is I've got a list of all the attendees, and I'm going to call out your name. And if you have a question or a comment or experience you want to share, please do so. This is a wonderful opportunity to get some real direct information from Sarah and from what is clearly an evolving situation here. So at this time, let's do that. And I'm going to, again, I'll just call out your name and take yourself off mute if I've not already done so for you. So let's start out with Eric Simpson. Eric, you have a question or talk?
No, thanks, Larry. Probably no questions. I think as a healthcare entity, we're up to date with all the information presented. So helpful for us to know that that we've got up to date information. I think more of our issue challenges are working with the different modalities that states are doing for procurement and sign up for provider enrollment. So I think that's more of our issue.
Yeah, each state has its own requirements. I assume each, even the counties within a state might have a separate requirement. So, Sarah, any recommendations on dealing with these different health departments, and particularly for employers and our vendor partners who work on multiple states?
Yeah, we've been hearing a lot about these challenges, and you know it's different for COVID vaccine than for something like flu vaccine because this is a federally subsidized vaccine and there are limited quantities right now, and so it is it's required to go through each of the jurisdictions' registration systems, and they each have common requirements, but I know that they each come across in a little bit different ways, so it can be difficult. So we're trying to figure out if there are any ways to make that easier, but definitely for companies that work across different jurisdictions, it's important to have a local contact each place that you want to be able to administer the vaccine.
Thank you. Amy Iverson. Amy, any questions or comments? Take yourself off mute, Amy. No? Okay. Andy Sherman. Andy, you have any questions or comments? Just take yourself off mute. Okay. Ashley Penna. Ashley, any questions or comments you'd like to make? Just take yourself off mute.
No.
Go ahead.
Nope, I'm all set. Thank you so much.
Oh, okay. That's fine. Brita Rearson. Brita, I know you just got on, but any questions or comments?
Not for me. I look forward to reviewing the video or the recording as well, so I can get the front end. Thank you.
Yes, this has been recorded and the slides will be available to everyone who participated. Craig Badinger, Craig, any comments or questions?
Yeah, no, thank you, Larry and Sarah. Appreciate the information. I work closely with Eric here at Premise Health, and it's definitely a lot to stay on top of for particularly us organizations that are servicing clients across the country in nearly every state. So, but this was certainly good information, and we just want to continue to position ourselves to support our clients and the centers where we're providing services as best we can here, as many of them are still in modes of where they're looking to return their members to work safely.
Great. Thank you. John Leisman, John, any comments or questions? Nope. Okay. Laura Stahl, Laura, any comments or questions?
Yeah, hi. I just want to thank both of you. Very informative session. And I work with Eric Simpson. We both agreed that, you guys did a great overview, and a lot of this wasn't anything new for us. But, from our perspective, having, multiple sites in almost every state, we really want to see like a national platform for reporting of vaccination. It's just been extremely complex, from our perspective. So that's all I've got.
Thank you. Yeah, Sarah, I had a question about that as well, reporting. If the employers and the vendor partners do the vaccination, what are the reporting requirements back? Do they report to the health department, the CDC? I mean, is this standard across the country, or is it, again, separate for every state?
Yeah, so I'm not an expert in the reporting requirements, but my understanding is that they need to report every vaccine administered to the immunization information system of each state and jurisdiction. And I know that that's been a big challenge for companies that are operating across multiple jurisdictions too. There is a new system called VAMS, the vaccine, I can't remember what VAMS, VAMS stands for, that is in progress. And we're hoping that that's something that might be able to help standardize some of this.
Okay, great. Thank you. Let me now ask Kevin. Kevin, you have any questions?
No, I don't at this time. Just echoing what everyone else has said. We at Progressive Health are here to support our employer, partners. Looking forward to get this vaccine rolling out and hopefully getting more of the workforce back into safe and productive work mode.
Okay, thank you. Matthew Hoff, Matthew, any comments or questions?
None for me at this time. Thank you both.
Okay. Mackenzie Decker, Mackenzie, any comments or questions?
Yes, first of all, thank you very much for the information. I agree. I thought it was very comprehensive. I'll echo what Eric said about the challenges faced when we've got companies across multiple states, and the variability and phasing across different states, as well as the variability in the definition of essential workers and who that includes, which changes over time within a single state and is of course different across different states. So that's tough, but we're doing the best we can, just like everybody else on this call is. I did have two questions. One is, do you have an idea of when the CDC vaccine finder will include COVID to be able to search through that? And then my second question, and I apologize, I missed the front end of this presentation, so I'm sorry if I missed it, but I'm wondering if the Johnson & Johnson vaccine gets approved at the end of this month here, will that also be federally allocated?
All right, so yeah, I was just looking for information on Vaccine Finder. I'm not quite sure when the inclusion of COVID in that is going to go live, but I have heard that that is forthcoming soon. With regard to the Johnson & Johnson or Janssen vaccine, yes, because it'll only be approved under the emergency use authorization as part of the federally supported program.
Sure.
It will have the same distribution model.
Okay, thank you.
Thank you. Nancy Flemans, I know Nancy, you submitted it on the chat on the questions, but you want to give your question now to Sarah though?
Okay,
Good.
can you hear me?
Yeah, go ahead.
Okay, great. Yeah, so I'm wondering about having to be pinned. We have a site that's gotten a vaccine already, one of our employers, and we were required to register as being able to give to the public, and this is a employer site. We're afraid to pull that pull that request, and we're now pinned in a map for the state that says that we're a place that offers vaccine. If we request for that pin to be pulled, or that we don't want to offer to the public because where the clinic is actually located within the employer site, will that cause us to lose access? Is this a federal mandate that's requiring this?
Yeah, I can look into that a little more. As far as I know, it's not a federal mandate, so I'm thinking that's probably the state mandate. And I think, you know, there could be a case made that if you are specifically targeting the, you know, the priority groups for the state, including essential workers in certain industries and occupations, or workers in any workplace
let the dogs out?
I'm sorry, workers in any industry or occupation that meet the other priority conditions, such as their age or medical conditions, then I think a case could be made for asking for your site to be a closed point of dispensing. But I'm not quite sure at the federal side. I'll look into that a bit more.
Okay, thank you.
Shannon Mason, Shannon, any questions or comments? Take yourself off mute. And Wesley Atwood, Wesley, any comments or questions?
I have no questions, thank you. Great job, Sarah.
All right, again, I'll open it up for anybody else who has any questions. I may not have identified you, maybe you jump down later on. Sarah, let me ask you, you talked about communications materials that were in multiple languages. I know a lot of employers have people who speak a variety of languages and have different cultural backgrounds. Is it possible for the employers or their vendor partners to obtain these different language communication pieces from the CDC, or possibly even co-brand them in some way?
Yeah, so CDC is posting the resources in different languages as they become available. We didn't want to wait until all the languages were available before posting anything. But if there are specific languages that you don't see that you think would be useful, feel free to reach out to me and I can check to see if those are in progress. Or, you know, feel free to translate them yourselves, but we're trying to get as many as we can.
Okay, great. Diana, any questions posted to the SurveyMonkey site?
No, I don't see any.
Okay. Well, at this time then, Sarah, let me thank you very much for taking time out of your very busy schedule to join NAWHC. I want to thank all the participants of this program. Again, the recording will be slightly edited and then posted, made available, as well as the slides. Be sure to join us for our next event coming up. Go to our website for those topics. We're going to stay on top of this, and we are a partner with the CDC in their continual discussions, and hope to share with you information. If you have other questions that you would like to have answered by Sarah or others, please do so. Let me know if we can be of additional assistance to you. At this time, everybody, stay warm, stay safe, and look forward to seeing you at a future program. Take care. Bye-bye.